Given the importance of data that we've outlined here, and you're coming across organizations and dealing with their data a lot, what are some of the most common data quality issues that you come across? And how might you advise these revenue cycle and technical leaders to keep an eye out for that or even fix them when they find them?
Yeah, that's an excellent question. A very good question. Part of that, I would love to have my technical staff next to me because they're going to give a layer of depth that probably I don't have. I'll give you my perspective on it. One is the contract loads. They're not accurate and they're not accurately interpreted. So the interpretation, the way you interpret a contract or a policy and then translate that into a system, that's very problematic. Like I said, I feel very confident I can poke holes in systems in those loads, in whatever matrix they use to load those contracts and policies and the hierarchy they use. That's a big data problem from a higher level. Obviously, as you get in the weeds and we create a parallel database, there's a lot of more, technical things I'm maybe ignorant of, but I've heard staff talk about them in terms of different types of coding, different types of data feeds they're getting from the clearinghouse, things like that. But what I see mainly that resonates with me is the translation of contracts or policies is not happening in a system in an effective way. It's incorrect oftentimes, especially in more complex scenarios. And that filters down to cause problems with patient estimation, with negotiating your contracts. It causes huge negotiation problems, withholding payers accountability, net revenue, impact revenue integrity, root cause and all those types of things.
Yeah, I think that makes a lot of sense. I've had this conversation with some health systems actually recently where the expected reimbursement that your system is showing you for a single claim is not matching what the payer paid, despite the payer believing they paid in full. A few things can be happening.
This show is brought to you by Real Partners Consulting, a free-to-provider vendor selection support company. We help healthcare providers find the right revenue cycle partners across technology, consulting, and managed services at no cost to you. If you like what you've heard from today's guest, or if you're looking for any other partner in the revenue cycle space, let us do the heavy lifting for you. Reach out to me, your host, Ryan Downs, on LinkedIn or at rdowns@realpartnersconsulting.com, and I will personally help you find the right fit. Now let's get back to the episode.
One of them could simply be that you're not calculating correctly because you don't have that level of precision that it often takes a third-party technology to get you to. But the other could be an interpretation difference between how your managed care, your revenue cycle team interpreted what's on a contract versus how it got entered into your system. There's one potential breakdown there. But then what you often see too is actually we interpreted our contract the way we think we should. We built it in our system the way we think we should. We're happy with the output. But at that point, now it's just a differentiation between how you've interpreted the contract and how the payers interpreted the contract. But unless you do those other things correctly, you can't even get to that conversation. And then it brings us back to policies and keeping up with policies. So I'm seeing what you're seeing. Just put it that way.
Yeah, it's very well said. And you made a great point that I didn't make. The calculation itself, if it's a complex calculation, and they're making them more complex. If it's a complex calculations, systems don't have the ability to marry those, many systems to marry those to the actual claim to get your expected reimbursement, because that requires, it's not just kind of a flat approach to taking your data and then marrying it to claim. There's hierarchies to that. There's carve outs. There's hundreds, maybe thousands of complexities with codes behind this. So you made an excellent point about the calculation itself is a problematic also.
Yeah, I think for those who haven't looked at a contract, and it's not like I've read through a full one. I mean, the contract between a large health system and a large payer, it's not X percent of charges or X percent of Medicare rates. It is maybe that's your default. And then here's hundreds or thousands of pages carving everything out and then pointing to all the hundreds of policies that are ever changing too. I mean, it's this vast network of, dare I say, intentional confusion, so that it's difficult for providers to keep up. And I think what I'm hearing with your typical EHRs, which would be your first built-in course of technology that can get you to that expected reimbursement, a lot of them can get you 90% of the way there. But there's going to be plenty of known examples where your current technology, if you're relying on your EHR, it simply ain't going to get you there.
Or incorporating groupers and things like, yeah, you're exactly right. Yes. You said that very, very well. Yeah. That's, you hit the nail on the head.
So calculations in and of itself, difficult, so many layers to these things. Thankfully here, and I think part of the reason we're able to have these discussions, you mentioned it before, it's AI, right? I don't think we could keep up with rules-based versions of this incredibly well, given the amount of change that's always happening. But now with AI, we're doing a better job of it.